Welcome to this short lecture on the biomechanics of breathing. We're going to be doing this partly on location from my shed, and hopefully by the end of this you'll understand how we breathe, but also how to recognise when somebody's not breathing efficiently and potentially quite ill. It's also linked in with the other lectures and talks we're giving over the next few months. Just take a moment to think about how we breathe. It's something we take for granted, and we do it without thinking. But we'll break it down. And in this talk, we'll talk about some of the physics of breathing behind it, the types of breathing. We'll have an overview of the anatomy, because we've covered that in a lot of other seminars, and we'll look at the biomechanics. So let's look at the physics. I'm sorry it's GCSE, but it's really important we understand this. The ideal gas law states that with all things being constant, i.e. the number of gas particles and the temperature, that the pressure and volume will remain static. Another way of looking at this is changing the equation, and you'll see that pressure is inversely proportional to the volume. i.e. if you increase the volume, you reduce the pressure, and vice versa. In our chest, we can change the volume of our chest and therefore change the pressure. We also know that gases will flow from a high pressure to a low pressure, and the inside of our chest and our lungs are connected to the atmosphere via the trachea and upper airway digestive tract, so it gives an opportunity for gas to flow. So let's now go to the shed. Welcome to Richard's Shed, and we're at the biomechanics of breathing. We're going to talk about the ideal gas law first, where we said that the volume a gas occupies is inversely proportional to the pressure. Here's a volume of gas inside the perspex. Here's a way of changing the volume. Let's connect this volume to the outside world, a bit like connecting your lungs and the inside of your chest to the atmosphere. Now let's change the volume. Reduce the volume, increase the pressure, air flows out. Increase the volume, reduce the pressure, air flows in. Still don't believe me? Let's see if we can prove that. Increase the volume, reduce the pressure, air goes in. Reduce the volume, increase the pressure, air goes out. Increase the volume, reduce the pressure, air goes in. Reduce the volume, increase the pressure, and air goes in, out. In, out, in, out, in, out. Haven't set light to that yet. Not quite as simple as that though, because we have some lungs inside our chest rather than just a space. So let's put some lungs in, represented by this dog sack. Here we have our volume, and I'm going to inflate them slightly, but if I reduce the volume that those lungs sit in, they go down, increase it, goes up. So I reduce the pressure, I suck air into the lungs, I reduce the volume and increase the pressure, I push the air out. Increase the volume, reduce the pressure in the chest, I suck air into the lungs, reduce the volume, increase the pressure and push air out of the lungs. You can see how the lung is getting inflated and deflated with the movement of the chest. So we've nailed the physics now, but we breathe in different ways depending upon the circumstances. Let me just show you a couple of my colleagues to see if we can demonstrate how we breathe differently. First of all, we've got Richard here, who's a very organised lecturer. You notice he's come to the lecture so early and so well organised. He's got time for a little bit of a lie down and a little bit of a nap. Look carefully at how he's breathing. Gently, the muscles of the abdomen just moving gently backwards and forwards, and that's all the breathing movement you can see. Well, look at Dick on the other hand. Now, Dick is not quite such an ordinary colleague of mine, and always late for something, always rushing around, and he just has to run up to the second floor at the physio lab, and you can see how he's really having to hold on. He's really puffing and panting, and really having to hold on. Now, work out why they're holding on. He's holding on. What he's doing in order to get that more breath into his lungs. And essentially, Dick is having to use the accessory muscle of respiration. He's using forced respiration rather than Richard, who's using quiet respiration. So let's look at the difference between the two. Firstly, quiet inspiration and expiration. We saw in Richard just his abdominal wall moving when he's lying flat. And here the muscles at work are mostly the diaphragm, just pushing the abdominal contents backwards and forwards, that small amount which is inside the chest, but also a small amount of movement of the external intercostals, contracting, lifting the ribs slightly, and then relaxing. And it was all very relaxed, and hopefully you got that impression that Richard was relaxed. The inspiration is a small amount of physical activity, then expiration is a passive movement. When you're standing up, the passive movement of abdominal contents with gravity downwards will pull the diaphragm down. When you're lying flat, it's a bit harder. And we're relying upon there the elasticity of the lungs to pull the chest wall back in after they've been expanded. We'll come on to that later. But remember, here it's passive expiration. Before we go on to the next slide, think about somebody lying flat who's got a massive tummy, even bigger than mine. Is that going to affect their quiet inspiration and expiration? So let's look at forced inspiration and expiration now. Remember the video of Dick? Certainly Dick was using more than just his diaphragm and external intercostals. So here at play, all the intercostal muscles are being used, but also accessory muscles of respiration, like those of the shoulder girdle and the abdomen. There's very active movement of the abdominal wall, not just on inspiration, but also on expiration. In order to breathe out, the abdominal wall is contracted, forcing the abdominal contents up against the diaphragm, reducing the volume of the chest, and increasing the pressure and forcing the air out. Think carefully about how a patient may or may not be able to use the accessory muscles of respiration and what might compromise that. Also, again, have a think about the chunky patient lying flat with the abdominal contents pushing up against the diaphragm and then trying to move those. Well, the anatomy is fairly wide-ranging. The sternum, the costal cartilage and the ribs are the obvious part. We always think about the anatomy of respiration. But don't forget the thoracic vertebrae and also the bones of the upper limb. Key skeletal elements for both quiet and forced respiration. These obviously got to be moved by muscles, and they start from the neck. The scalene muscles and sternocleidomastoid can stabilise the first rib and elevate the clavicle. And then the muscles of the thorax themselves, the intercostals between the ribs and the innermost intercostals within the ribs, serratus posterior and the diaphragm. Don't forget the muscles of the upper limb, not just those attaching onto the chest wall, but also those to stabilise the upper limb in forced inspiration and expiration. So why have I gone so far-ranging about the anatomy? Well, if any part of this anatomy, it may affect the way your patient can breathe. A person with a kyphotic thoracic vertebrae due to metastases or osteoporosis isn't going to be able to breathe as well. An older person with a bilateral humeral fracture may not be able to undertake forced inspiration and expiration. If they've got COPD, it could make a big difference. So have a think about the whole of the patient and the whole of breathing whenever you're seeing your patients. So how do we increase the volume within the thorax? Well, there's two predominant movements. The first is contraction of the diaphragm. As the diaphragm contracts, the diaphragm pushes any abdominal contents within the thoracic rib cage inferiorly, thus increasing the volume for the lungs within the thorax. This reduces the pressure and air flows into the lungs. The second movement is that of the ribs, and this has two movements. There's an outward movement we describe as the bucket handle, and a forwards movement we describe as the pump handle. I think it's time to return to the shed. So how do we change the volume of our chest? This represents the diaphragm pretty straightforwardly. That's fairly easy to see and understand. You see the volume changing straightforwardly. But we also change the volume of the chest going outwards as well. We describe that the bucket handle. Because the ribs, imagine the ribs are shaped like a bucket handle, represented here. If we move this bucket handle out, the distance between the handle of the bucket and the centre of the bucket is further away, and that potential volume is increased. So that's the bucket handle effect. We've got two sets of ribs, so I'll just get another bucket handle. And here you can see we're going to increase the volume on both sides as we breathe in. Lower. Well, that's sort of looking from above downwards. There's also the fact that the ribs are quite well designed to have something called a pump handle technique. We now look at the rib cage from the side, and I'll represent my rib cage with this box. With the ribs slightly sloping downwards, you can see the volume of my box is smaller than when the ribs come flatter. So as I breathe in, I increase the volume of my box by levelling out the ribs, reducing the pressure inside and breathing in, and then as they come down, the volume of the box reduces, increases the pressure, forcing air out. So that's the technique of the ribs. It's not quite as simple as that because there's also other forces involved. If we represent the lungs, or the elasticity of the lungs, with an elastic band inside the box, the elasticity of the lungs with this elastic band. When we breathe in, the elastic band becomes taut. Then when we relax, the cardboard box pulls down. We increase the volume of the cardboard box, the elastic band becomes taut. We relax, and the elastic band pulls the cardboard box to a smaller volume. Same with the lungs. We breathe in, and the lungs are stretched out. We relax, and the elasticity of the lungs pulls the chest down. And that's acting upon the bucket handle, but also the pump handle action, and also the diaphragm. So we breathe in,
The lungs are stretched, we relax, and the lungs pull the chest in.
So here are some of the classic diagrams we see in the books of the movements of the chest wall. And here's Moore's Essential Clinical Anatomy. Hopefully in the shed you understand these movements fully in 3 dimensions.
So we've seen how the ribs move outwards and forwards. Let's have a look at the articulation of those. And to do that, I'm just going to pop to my cup. So here we have a vertebral column with the thoracic vertebrae from T1 to T12, and these are special because they have articular surfaces on them. On the body, in a facet or demi-facet joint, and on the transverse process. The ribs also have 2 articulating positions on the head and the tubercle further along the neck. This dual articulation between the rib and the vertebrae allows for that pump handle movement and also the bucket handle movement for the expansion and reduction of the chest volume. The ribs also articulate anteriorly between the end of the rib, the costal cartilage, and the sternum of the new rib. Any disease process in any of these joints may lead to the inability for the patient to breathe freely easily.
So we've focused on inspiration predominantly, and we have touched on expiration, particularly enforced expiration. But on quiet expiration, the crucial part is the elasticity of the lungs, which can pull on the chest wall and pull on the diaphragm. But if the lungs are only attached at the mediastinum and can glide and move freely within the lining of the chest wall, how can they exert their elasticity and pull on the chest wall? I feel there's another visit to the shed.
The elasticity of the lungs pulls the sides of the chest wall down and the diaphragm up. But I hear you thinking, the lungs are only attached to the rest of the body but at the mediastinum by the hilum. So how possibly can the elasticity of the lungs be pulling the ribs and everything in? Well, remember we've got 2 layers, 2 special layers. We've got the pleura. We have the parietal pleura on the inside of the chest wall, and we have the visceral pleura over the lungs. And these 2 pleura sit together, and hey presto, they're stuck together. The visceral pleura and the parietal pleura are stuck together, and hey presto, there must be something else at play. And there is. There's surface tension. Because between the 2 layers of visceral pleura and parietal pleura, there's a little bit of fluid. And that's just water, nothing special, not glue. So now if we put these 2 layers together, hey presto, they're stuck together. And that surface tension is enough to keep the elasticity of the lungs pulling the chest wall when we're breathing out. It's also really important to remember that if we introduce air between these 2 layers, so I'm going to stab somebody through the chest now and introduce air. Then the 2 layers are no longer stuck together, and the elasticity of the lungs won't be pulling the chest wall back together. It'll be allowing the lung just to collapse down into a little small hole in the hilum and next to the mediastinum. Hence you get a pneumothorax and a collapsed lung.
We'll go to the shed to summarise what we've learned.
So what have we learned from the shed? Well, breathing's not just about chest movement. We've seen it involves the upper limbs as well, particularly in forced respiration. We've looked at the physics of it, changes in volume, changes in pressure, and flow through the trachea. We can use that information to ensure you can recognise a potentially ill patient with breathing difficulties. It may be a subtle sign of using accessory muscles of respiration in the neck to stabilise the first rib and elevate the clavicle, or they could be holding on as Dick did after running up the stairs. You can also use this information to optimise your patient's breathing if they're suffering from other conditions, or maybe post-operatively. If you sit them out, you're going to not be splinting the diaphragm with the weight of their abdomen when they're lying flat. If you mobilise them, they can hold on to different parts and use forced respiration. And if you give them proper analgesia, again, they can breathe more freely. Lastly, hopefully you've got some better understanding of the disease process which may affect the lungs themselves, and how affecting the elasticity of the lungs can affect the way the lungs work. So treat the patient as a whole, because breathing involves the whole patient. I better just put those bones back in my cupboard.